wow, it's already 23 people.
Okay.
So I think we can start. It's
Yeah, we
already
can
12.
start.
So I'll bring all of them in. Then I'll just start introduction.
Yeah, no problem.
Hello and good evening. Thank you, Adam, for joining. It's really lovely to have you. I know you had a busy day and you came all the way, like you just finished your vacation yesterday, and today you are giving the
2 days
webinar.
ago. 2 days ago.
I'm, um,
Hello.
I'm really happy you can make it in such a short time. And we have lots of people joining. Like we're already more than 35 people now. Oh, more people coming. So I'll just give you an introduction about Adam. Dr. Adam is a dear friend, and he's an extremely intelligent guy when it comes to digital. He is already working on AR technology that works with Apple Vision Pro, and how to place implant with augmented reality, and it will be much more easier. So it's next generation navigation that he's working on. He's a PhD in implantology, and you already have seen his cases posted on the on different social media platforms. He is working with Root for a very long time. I'm personally a big fan of Adam and his knowledge, and it's going to be a really interesting webinar. He's going to share all the insights, especially when you work with full arches. What are the key points that you need to follow, and what is the real blueprint to achieve good results each and every time? So thank you so much, Adam. I give you the stage. Please go ahead.
Yeah, hello guys. I'm really amused to lecture for you to do this webinar. Thank you, Salman, for this introduction. So, guys, in Poland now it's a little bit late, but I don't know from which time zone you are in, but still, we will try to keep this snappy, and I will show you some things, for you to think about. So this lecture will be about precision, predictability, and progress, the digital thread weaving through the implant dentistry. I'm a professional that started doing implants when it was all analog. Now everything is digital. And the switch in between these two styles of working is really something that is added value to our work. And I'm really grateful that I had this possibility to learn analog stuff, because sometimes digital sometimes have some hiccups. And it happens from time to time to every professional that uses digital tools. So we have to keep in mind that these are just the tools, the most efficient and the most crucial thing is a implantologist. It's a guy that places implants, not the tool. The tools are just for us to help. So, I don't know, this is one of my patients. He came to the office and he was having some complaint about his aesthetics, phonetics. Also, his wife was complaining because she told me that he has some health issues related to his teeth. So after dumping the smoking, because he was a keen smoker, and after maintaining the proper hygiene, even with these lesions and this hopeless teeth, as you can see, they're really, really nicely clean. We knew that we can do something for him to help him to redefine his teeth chain and redefine his smile. So it's just in the beginning and this is the end. And to be honest, the time spent between these photos is approximately 5 hours or so. And this is the advantage that digitalism gives us. And I will show you some stuff from the early days of my work. and I will show you how it's done nowadays and how these things can enhance our work. Yeah. Quality evolution in implant workflow, it starts with DSD and implant planning. I'm doing all things by myself because I had some issues with the guys who are, offering paid services for, doing things like DSD or planning the guides or doing other stuff. It's sometimes we have to struggle with technicians. But it's more flawless than doing like surgical guides. And on the very beginning of my journey in implant market, I had some issues, so I started doing it by myself. On the left side, you can see the patient, and it's a case from, I don't know, a few years ago. I have done, the photos and then a classical two-dimensional digital smile design. So we can see the outline of the teeth. We know where the teeth should be placed, and it's easy to read, even for to communicate with the patient. But it doesn't give you any information about molars, premolars, the teeth chain, on what angulation and what relation it should have to other structures. So on the next photos, upper ones, you can see that there is a cone-beam CT, and it's merged with intraoral scans and with a face scan. And it's finished with the teeth chain that I managed to design. And this teeth chain can be related to the certain planes, like occlusal planes, like a Frankfurt plane, Camper plane. It depends on the operator. Yeah. So on the lower photos, you can see that the patient is quite. We have this. This is the same patient with the temps on. After the implant placement, and you can see that we managed to transfer the project to the patient. More or less, it's the same. So it helps a lot and it works. Other evolution is project and design. So most of you probably are really common with cone-beam CT. Nowadays we have AI agents that help us do a lot of stuff for us. So basically, we can just push the button, and it's easy, and we can have segmented bones and teeth. So also with other anatomical structures like nerves. So you can see this on the photo. Then we merged it with intraoral scan. Yeah, so we have intraoral scan that is completely in place, upper and lower. And then we have the face scan. Yeah. And with the face scan, we can, I don't know if most of you are familiar with the face scans. I started using face scans when there was like a Balus project. It was dumped by his founders, I don't know, in 2020, something like this, maybe 21. But I was really happy with it. But then we were able, to grab only we were able only to grab like face in one, or maybe smile, maybe grim. Nowadays we have scanners that are better. The resolution of the scan of the face scan is very crisp, and we can see many details. And also we can, with the use of the software, we can merge together multiple smiles, grims, and it depends on you what you want to see. When you want to see aesthetic zone, you ask the patient to grim, to roar, and you can see what will be the smile line, the aesthetic zone, and where do you need to place the teeth to look natural and to everything be really, really in place. And then you can, if you have enough bone conditions, or maybe you need some bone reduction because there are some bone deficits or malformations, maybe some codon. So then you know that you need to trim the bone, do some kind of a bone reduction, you know where and how much of the bone should be reducted. And then you know also where to place the implants because it's prosthetic driven surgery. When you're placing like simple implants, like single implant, maybe two implants, then you can easily navigate with landmarks in the patient's mouth. You have like a neighboring teeth, adjacent teeth, so it's okay. But when you're doing full arch, sometimes you know you place the implant, then you navigate with this implant, and then you see that all of the implants are a little bit tilted, and then some issues with the prosthetic part may occur. Yeah. So when you have a nice project, you know where to be, you know on which pattern and where you should place the implants, and you know what the pattern of the implant is. Then you generate the surgical guide. You can see on your right, you have surgical guide. And then, you know, you can do reduction. Also, you can do secondary guide. In this simple case, I did like a really, really simple guide that was supported with one tooth. It was also mucosa supported, two simple pins, and only for a pilot drill because it's more precise for me nowadays. This is a short film, how it was done. I also have used pentapins. I know Salman will probably have this STL files. I will send him if any one of you would like to print it by yourself. These are the pins on the palate. You just print them. They're disposable after the case. You just put them in a trash bin. And these are really cool because, you know, after the operation, you have swollen tissues. Sometimes the scanner has problems with scanning. So when you have this pins on the palate, you know, you just place them before the surgery. You do a pre-scan, then you do operation, extract the teeth, place the implants, use any type of a scan flex that you want, or and then you can merge them all together with these pins. And also it's easier for scanner to start scanning because you're scanning from the landmark that it's not being touched. You know, it's not swollen, it's not moved, and it's always on the plate. Okay, so quality evolution surgical guides. This is surgical guide approximately 1 decade ago. There was a materialized company, and they were selling surgical guides and services with 3D printing. It was extremely expensive. So on some day, the patient came to me and told me, "Man, I just really want to have this full arch done in my situation. I'm on the implants. I'm using the removable. So if there is a possibility you would place the implants in 2 days, I would be really happy." And he was, you know, a broad patient. So I just have taken the impression, I have sent it to the lab and asked the technician, "Can you do a splint for me?" And with the splint, I was navigating with a pilot drill. You know, it's like a really, really primitive surgical guide. Yeah, but it worked, you know. Then the guide was off and I carried freehand. So it's more or less primitive, but I use this technique today. Maybe not the Erco press, but with 3D printing. And this is it. Surgical guide that it's, you know, supported on the teeth, partially on the mucosa. For really quick cases, easy, really precise. There is not much play with the drill inside the sleeve because there are no sleeves. Yes. But you have to really keep in mind that you cannot reach high speeds with the drill because the plastic, you know, the surgical guide will melt. But it works for a pilot drill. Then you carry on with the freehand. But the very beginning also, I was really happy with the surgical guides that I could design. that were totally navigated, fully navigated. You can see surgical guide with sleeves. The sleeves were being pressed in the surgical guide. This is stackable guide, so the upper part was switched till this position. The first guide was sitting and was supported with the existing teeth of a patient. The lower part was, after flap elevation, was supported by the bone. Then the pins were being placed. After this pins placed, I have taken the upper part, extracted the teeth, grinded the bone, so the bone was really grinded still till my surgical guide. I knew that this is the level that I wanted to do the bone reduction. And then I have placed the upper part. This is a secondary guide, and with the secondary guide, I had made the I have made uh, mm, I have made the implant placement, and then I have placed the implants through this guide, so I knew the exact depth, angulation for the drill, and also for the implant. These guides are giving you on some point some issues, because you can see through this guide the irrigation is limited. Also, there sometimes cone beam CT is giving you a little bit awkward information, and during the surgery you just basically have to follow the drill protocol. You cannot change anything, and when you want to change, you have to take the surgical guide out and look if everything is okay, and it's really time consuming. So what came in handy was this open guide. You can see that they are having the slots on both sides, palatal and labial, and when you want to do osteotomy with this contra angle, the contra angle has this fork on top of it. This fork comes into this sleeves, these ports, and you see the drill. You see the drill penetrating the bone. The irrigation is not a problem. And this Twinkies guide is really, really nice, but it was expensive and it had some issues, because it was really bulky, and some of the patients, we had some issues with fitting in this surgical guide. So for classical, 6 implants, straight implants, 4 implants, tilted, it was okay. But with other type of implants that we will speak about today, it was really a little bit problematic, let's say. And this is quite modern type of guides. You can see the SLS work. So it's made out of the metal, titanium in this particular case. It has the sleeves for the pins. It's on the magnets and positioning pins. The 3D printed part is fixed on a teeth, and the secondary, the framework is sitting and supported on the mucosa. And then you switch after the extractions, and here you don't do really bone reduction. So this was not the bone reduction guide, but it was stackable guide. And then you place the implants. You can see there was one pterygoid, so it is for the drill, that is primary drill for the pterygoid implant, and the rest is for the fully navigation. Yeah. Okay, so provisionals. Yeah, more than provisionals look like this, and it was a hell of a job, to do. This was ugly. It worked because patient had something in his mouth, but it was PMMA. It was being milled by the technician, then pick up in the patient's mouth with the acrylic, and it was smelly and a little bit problematic for both sides. So then I have switched to intraoral welding. So inside this structure, you have a titanium framework. You can see you cannot see our wire, because there is a wire 2.0 wire inside, and you have abutments. You have 4 abutments that are, intraorally welded to this wire with the intraoral welding. It's a nice phenomenon that it was introduced to me. My friend introduced to me this intraoral welding, and then I attended the Gidis course, Marco de Gidis, and it was really, really good, and it was working, but required a lot of chairside work. The outer shell, as you can see, is there is a line. It was 3D printed, so it was picked up in the patient's mouth, and then you have to sit and finish its chest. You have to glaze it. You have to polish it from the mucosal side, so you can have like a nice aesthetic outcome for the temporary, but still it's really, really requiring. So we were looking for something that it will be quicker and easier. And the first guide that I showed you, that 5 hours metamorphosis, was the guide that we had just printed from the Onyx sprint tray resin, which is really durable and really it has flexural strength that works. And it's 3D printing is really quicker than milling, so you can do it also in-house in your office. So what was the workflow? The workflow was that I have scanned the patients after the surgery, and I have sent the scan with the positions of the implants to the lab. And the technician was waiting because he knew that there will be this window after my surgery that he wanted to fit in, and he was having all the data, the face scan, intraoral scan, Cone CT, my project, everything. So he knew what he had, everything to produce, to design the teeth chain. And he just placed the implants, and he has sent me the STL file. It was like a less than half an hour. Let's say this was half an hour. So, and in the additional half an hour, it was printed, because with the printers that we have also nowadays, it's possible to print this teeth chain in half an hour. So in 1 hour, you have something like this, but you have also to characterize it, you have to glaze it, you have to polish it. So let's add additional 30 minutes. And with the 1 hour, 30 minutes, you have provisional from the multi-unit abutment, and it's ready to be screwed on the patient. So for me, it was really nice. And this is the outcome and the gingiva and the profiles that we end with this type of temporary. Okay, yeah, and this is, you can see, this is the 3D printer that I use. Unfortunately, I didn't catch the 30 minutes. Now it's waiting because the resin is dripping. So this mini plate gives you a possibility, to print 2 arches simultaneously. And we did some research on it with guys that for the biomedicines from the Scientific and Technical University of Wrocław. And we are publishing, I think we'll publish some new research, because we have new data with the sprint tray resins and the rest in upcoming weeks or maybe a month. And yeah, and this is what we are aiming at. That some of you may say, man, this looks like a ceramic, the toilet aesthetics. But to me, the thing that I aim at is the function. The patient wants white teeth. For me, it's not a problem. We can do something like this. Is artificial. We can do more natural, but it's aesthetics. And this is like for me, it's like maybe choosing a color for the car. Yeah, if patients want something like this, not a problem. But we have to look at the pink and the red aesthetic, the pink and white aesthetics, and that everything is really healthy and it looks really nice. Okay, so guys, transfer of the data to the laboratory. Articulation. Most of you are doing implants probably. Most of you also are general practitioners. So Some of you probably use articulator and face bow. Back in the day, I was using analog stuff. You can see on the left. It was a little bit problematic because the key that was sent with the fork to the lab sometimes had some issues. Somebody hit it. It was very delicate. We had only 2 of them, so if there were more patients on the day, we had problems with using face bow for articulation. So nowadays we are using Axoprisa on right. You just clamp the face bow on the patient's head, and you have to scan this long pod that ends with the yellow biting edge, and it's really easy. Everything is digital, but you have to follow the simple rules, and you have to know your scanner and which function like AI to switch off because it's cutting it off. But basically, you just change the biting tips, and you're easy with the scanning and sending the information to the lab. And what the laboratory does, he's mounting, your scans in the articulator, so you can see that everything is really, really aligned, and yeah, and it's working. And the technician can work with the articulator and can send you the work that is in static occlusion. And if you want dynamic, unfortunately, you have to work it in the patient's mouth. But still, there are some possibilities, like do you use something like I don't know, jaw motion analyzer or something like this? But we had ModJaw, and my friends are using ModJaw.
So Mojo and the SDI Matrix. So these 2 companies are quite coming good on this modality of dynamic occlusion. But I think to get it for all the users, I think at least we should get the static occlusion correct initially.
Yeah. So
Moving on to this.
if we are speaking in general, so it's static occlusion is the basic stuff, and dynamic is something that is added value. Yeah.
Because I think there's one more reason to this is all these machines are quite expensive, and it's a huge investment for some of the clinics initially. So I think the first and the foremost way is to just get the static occlusion correct, and then leave it to the temporaries to design the patients and to adjust the patient's occlusion. So that's like the old way. Let's do it the old way, and eventually, like when you have the ModJaw,
you add the stuff.
Yeah. Then you have the musculometry, then you have the TMJ location and the pinpoint and the actual centric, and then cusp and fossas. It's the way you do it actually, but the old way always works most of the time without any
guys,
investment.
you see how intelligent is this guy? Really, I'm amused when we speak all the times. I also will learn something from him. So getting back to the presentation, transfer data to the lab. Thank you, Salman, for your input. Adding something to adding going further, we have intraoral scans. Yeah. So guys, back in the day, also we had some issues with the scanners. We were scanning everything that we could, but we had problems with the implant positions. So what we did, splinting, the copings were being splinted with the transfers. Well, this is for the obviously for the transfers for the open tray impression. They were splinted with the floss. You can see that there are some dental floss particles, and with the flowable. After curing, it was being cut, re-screwed, and then glued all together also with the flowable. And then we have taken the impression. The plaster model was being casted in a lab technician's office, and he, with this scanner, he was table scanner, he was able to scan everything at one take. So he had this proper position of the implants, and he was merging everything all together. With the upper arch, it was easier because you have, this marks here, you have palate, so tubers, so it was easier. For lower arch, it was more or less precise, but the position of the implants were really precise. Then we tested some solutions for this problem, and some guys were coming to the market with the ideas that let's make some kind of improvement for the flags, because scanner is scanning, adding and stitching all together everything that he sees. So if he will see two scan bodies at one take, it would be more precise. Then we moved. This is Apollo smart flags. They are really cool. I use them till today. So it's really cool stuff that really works, and I'm happy with them. And so this is something that you can initially work with. Then we have photogrammetry. I have used the external photogrammetry. Here you have Hux. Hux also works. This is shining solution for the scanning, intraoral scanning problem. So you scan it. This is let's say kind of a photogrammetry, but on the test, Sheffield test, it comes really passive. We do passivation jigs or bars, and and it's really helpful. So we can do it digital. Here we can see the case that has pentapins on the palate. So when you catch with the scanner the position of the implants, then when you want to scan, the scanner asks you to scan the flags, and he asks you to scan the tissues, and the tissues are swollen. Maybe not in the anterior part, but in the back, on the sides, you can see they're a little bit swollen. They're red, and scanning from the palate side gives you these pentapins positions that are really untouched, so it will be really accurate. Okay, so quality evolution, final restorations back in the day. This you can see, this is porcelain fused metal. This porcelain fused metal was really cool thing. It was aesthetic, it was durable. We had some issues from time to time with the passivity. But still there was a lot of opaque that you can see. There was chipping issues. The chipping issues were really brutal thing, because when you want to fix it, guys came up with the ideas like let's repair it, or maybe we use composite or other solutions. Nothing worked. So everything, the whole porcelain should be sandblasted and put again a new layer of the ceramics. So I'm really happy that we managed to switch to something else. This is zirconia taco. This is full. This is full zirconia, and it's being milled. Inside you have a titanium bar that is. It has this abutments. It's not abutments. This is from the multi-unit. This is not milled from the multi-unit because it has this T-basis. And nowadays we can use something that is even more fun to work with, because there are less pots and there is less possibility to do something wrong. So when it's milled straight from the multi-unit, the bar is milled straight from the multi-unit. It's let's say less complicated for the technician, and it's less expensive, and it looks really stunning. For me, this type of work nowadays, also this is zirconia. It's really durable, it's aesthetical, and the patients are happy. And I from time to time we have some issues with the decementation. I had like two full arch cases. One, it was like 5 years old, and one was 2 years old. and the full arch was cemented. The zirconia taco was cemented from the titanium bar, but we sent it to the lab. The patient was on the during the laboratory work. There was used 3D printed or milled temporary because the technician is keeping his projects, and then it came back. So for the patient, it was also good. So some guys ask me, man, why do you extract all the teeth? Because it's maybe it's not it's not good for the patients. Everything that we want to do intraorally is we want to do less harm. But from time to time I have patients like this. You can see this in the circumstances you have even problems with placing the implants because with this periodontal disease, with this bacteria, the lack of a hygiene. If you would do fixed restoration, I think the patient wouldn't have time to develop the hygienic habits. And I wouldn't be happy to place the implants in a case like this immediately. So what we do, I have scanned the patient. I have designed 2 removables, upper and lower. It was 3D printed in office. I have placed like 4 implants, temporary implants, with the ball head attachment and with the pickup. I have the temporaries in the patient's mouth. So these are removables, but the lower arch is implant supported, and after the healing period, patient developed proper hygiene. We have spoken a lot about her smoking also. She dumped the smoking, so we were able to provide her with this 6 upper and 6 lower implants, and you can see the provisional in the patient's mouth. So she was quite happy. This was when we did the photo was taken when we did the lower arch. Okay, so full arch is a kind of a holy grail for implantology. I remember when I started doing implants, when I had this possibility to do first full arch. For me, it was like, oh man, I'm really happy with it. So you can see upper and lower arch. We provide the patient with the implants. The lower arch is, Salman also asked me about, doing monoblocks, and these monoblocks were being placed with the surgical guide, and there is econometry that is used, but this is not something that we speak about today. But upper arch, like 6 implants, straight implants, it was really good and fun to do. But the circumstances changes. More and more patients are having problem with atrophy, the pneumatization of the alveolar arch. The shrinking of the bone. The bony conditions are really bad. So what you're going to do, you are narrowing, the amount of implants. You're tilting the implants. You're still tilting the implants, and then you have situation. Oh, I don't know what it's doing here. I know. We have this situation that with the long implants and tilted implants, when you try to place the implant and you have like a surgical guide that it has sleeves in it, you can see the play of the drill in a new sleeve. Yeah, so maybe the drill is a little bit used, but still it has a lot of play. So when you're doing sleeveless, you can see the drill has it's spinning inside. It has a little bit, friction, but still it's spinning inside, but it's not moving. It's not having that amount of play. So for me, with the longer implants or tilted implants, it was really easier to use guides like this. This is mucosa supported guide for the pilot drill, so you can go really flapless, and then when you have the osteotomy for all the implants. You take the surgical guide out, you prepare the flap, and you drill with a free hand, and you place the implants. You can see everything is done under your eye, and everything is in place. So use it for the tuberopterygoid implants, remote anchorage. You have implants that are they are piriform rim implants. Also, you have tuberopterygoid implants, and you take use of the existing bone of the patient. And when the circumstances, the bone atrophy is really severe, you have like some bone near the platform of the implant, then you have to go a little bit transinal, and the apical part of the implant is in the piriform rim. So here you have a nasal lift because we don't want to perforate the nasal membrane. Yes. So you go transinal, you protect the Schneiderian, and you protect the nasal membrane. We just, with the surgical guys, we just don't want to have complication like this. This is a complication of one of my students. He was a little bit shaky and he pushed a little bit too much. So we have an implant in the parapharyngeal area. It was supposed to be tuberopterygoid implant. Unfortunately, he pushed a little bit too much. So we were able to fish it out. But everybody in our professional work, we just want to omit situations like this because these are stressful for us, stressful for the patient. We have complications. These complications, make you make you sometimes from time to time to rethink if you're doing it right, if you still should be doing it. So what complications you can have with this type of implant. It's like if we had play with the short implants and short drills, you can see here you have really, really long drills. And even with the sleeveless, you can see how much play you have. And compared to what we designed and what we obtained, we really can go and have a really nice outcome. And we can follow our path and design that we have done before. But to do so, we have to change the design of the surgical guide with its limitation. We have to know the limitation of the technology, So here we have surgical guide that is bone supported. It has a window for the antrostomy, and we will do the antrostomy with the piezo. And also, sleeves for the fully guidance. So you can place other implants fully guided. You can see here, this is other type of the surgical guides. We do a big antrostomy because it will be filled with the implant. We see a little bit here in the Schneiderian, but with this visibility, we're able, to cover it or suture it. And this is the design that helped a lot with the piloting of a drill, because you can see the sleeve, and then you see remote support for the drill that gives you 2 points of support, and it eases you with the big surgeries. So we can end up with the implants placed in a design that you desired. And when you place, as a surgeon, when you place the stitches, the prosto, after healing, doesn't know if there are zygos or tilted implants or pterygoids. He sees, 6 implants, 7 implants 5 implants, but still they are, in the middle of the alveolar arch, or something that is, remaining of it, because mostly these patients are really in a huge atrophy. So this is how, maybe it looks like it's really complicated, but these designs give you a lot of information what you will be facing during the surgery. This is like, when I design these cases, I know what problems, objectives I will be, facing during the surgery. Here you can see that I knew that I have to do a little bit bone reduction, then place tilted implant, zygos. This is, let's say, a classical PATSI, pterygoid anterior tilted zygomatic implants. Yeah, so PATSI. So transinal, I know that there are professionals that are saying that let's go outside the sinus. For me, and transinal is, till now, it's a way to go. And also, for me, the zygote that I don't place is the best zygote. So if we have the possibility to omit the zygotes, it's easier. You have palatal approach, tilted implants, and many possibilities. This is last resort implant, but still it's needed in this presentation because I want to show you that even with this long implants, when you know what to do, it's something that you can easily achieve also the success. Okay, so which part of the workflow that they have shown you with the full arches needs some more progress? For me, navigation. Yeah, so I'm maybe not. I'm not objective because I have some interest in it, but still I have used Navident and I have used XNav. They're quite cool. They are helping. There is a learning curve for them to learn how to use them. Every of these digital tools have some kind of a learning curve, but still you have to look aside. You don't look directly on the patient. And and there is some problem. This is my assistant that she's scanning. It's not about implant placement or scanning, but they are similar in the ergonomic way. So you look at the patient and then you look aside, then on the patient and aside. So our intern came with the idea that she will be scanning the patients with the headset on. So Metaverse was helping her a little bit. So she was scanning and she was having, the monitor, the virtual screen in front of her eyes. So a few years ago, we have came up with the idea that maybe we should do something with the navigation. We started with the HoloLens 2. HoloLens 2 had some issues, and on that time, we have dumped the idea of doing, augmented reality. And now we have become, Apple official developer, and we started doing something for the navigation. So you can see on the left side, I'm operating in a classical method. So I'm using my loops. On the right side, something, the pose is the same. Maybe not the best ergonomics on the both sides. But still, you do the same. You just look at the patient. You see the patient. It's not that you look at the monitor. You don't look aside. We are, we as a group pathologists, we are used to look at operational field. So when you have these goggles, you see the patient. It's not that you see screen or something. You see the patient. And this is the screens from operation. You can see that I'm operating. I'm doing osteotomy. We are using these trackers. It's now it's like maybe let's say that we are developing this. Yeah, so it's not that ready for commercial use. Maybe some kind of a teaser for you to see in which way I think this will go. And knowing how the industry is growing, how is taken by huge companies, we were thinking, because we were really a startup, we thought maybe what animal should we name after, and we thought that the honey badger is really good because he wakes up in the morning and he chooses violence. So the badger it's working like this. This is footage from the iPhone. So you can see that there is a hologram that is, glued to the drill. So you have not only the real drill, you also have the virtual drill. Also, when you put these markers on the patient, you can see through the markers, through the lip, through the tissues, the placement of the implants. Also, you can render anything, the nerve, you can render sinuses, nasal floor, etc. This is really nicely working on the iPhone, iPad. And for us, we have done some research on it, and it's really comparable to the surgical guides. But still, this is, this is recorded through the iPhone. So you have stereo, you have mono vision, so you don't really get the depth of your operation, and the headset gives you this possibility to have this depth, but it's unfortunate recording from one eye, so it's not aligning like this here. But you can see it's really, really nicely working. So we have done this research. Research said there is really nice discrepancy on both surgical guides, classical surgical guides, and our Baja. So you can copy this or do a screenshot and read it. And I think we will follow with the next studies. We're also trying to find new headsets. We have something on our head because, as we all know, Apple company is wonderful, but it's really, really closed. So they don't want us to have an access to the source code to use all the values that the goggles have. And this is how the operation looks. We just operate, and we have this bar with the implants. The vision is still, all the time the hands have higher higher preference than anything else. So if your renders will become in action with the hand, unfortunately the hand wins. So you have to align everything. And here we have the placement of the implant. This is classical root form implant. Nowadays it's root. Sorry. Nowadays root. I just placed a little bit of the antibiotic inside because I didn't want the implant to fall. Okay, and you can see the drill with the implant. It's a little bit off because still it's trying to find the best camera to record, and then we will place the implant. It's a little bit jumpy here. And you can see the QR codes are also a little bit off because still it's recording from the one eye perspective. But still we are able to push the implant and drive the implant to the patient. Here we had the patient from the first photo. This was our design. And this was the videos that I have shown you were recorded, let's say, with the Mark I Vision Pro. This is the second generation with the Muse from the Logitech. So you can see on the patient we have sinuses, we have nasal floor, we have holograms of the implants, and it's still a little bit jumpy. It's still a little bit off because it's recorded from one eye, and it's when you're operating, it's really in point. And with this use of this Logitech Muse and other technologies, it's more, you can see it's more stable. Yeah. So we are also doing the progress all the time. Yeah. Guys are having fun of me because when they don't see what I see, and you can see that in the background there is a party. The patient doesn't mind because it was some relative of them, and he was a volunteer for the research and development. He told us, yeah, let's operate on me. I have no problems with it. And you can see we are pushing and doing the osteotomy. And also the muse has it's cutting with all the external renders, so it should be, this upper bar should be a little bit to the side, but still we are able, to do the osteotomy. And ending this, you can see this is the how the implants were being placed. So they are more or less in this design that we aim for. This is our site. This is our, you can scan it with your phone, or you can just Google it, badger.org, and find us on the social media. Also, you can attend courses. I think we will do some courses. Salman, maybe you will speak about something like this.
So thank you so much, Dr. Adam. It was really informative. So we got a taste of the past, present, and the future in 1 hour, like how the current things are and how it will be moving in the future. And to be honest, like for me, I'm a fan of Badger because you have minimized a machine of almost 100 kgs into nothing. So
Yeah,
there's
yeah.
lots of space which will be available in the clinic. You can just do it with AR glasses, and that itself is a huge innovation. So uh, I would all I would really like to invite you guys. We have something really amazing coming up in Colombia, Bogota. You can see it at my screen, and you also have this beautiful picture, like it's an AI pic of Adam dancing, like doing salsa in Colombia. So we have this amazing course in May from 13th to 16th in Bogota. And Dr. Adam will be giving an insight of everything that was narrated to you in this webinar. We will also have live patient demonstration surgery. And it is not only restricted to two-piece, we will also talk about different modalities from root, different indications, like it's from two-piece, root-R, M implants, and also monoblocks. And there will be also tips and tricks shared by Dr. Adam, how to take the scans effectively, because I think this is the major problem that everyone is suffering now. Whosoever is doing full arch prosthesis, scanning is a big issue. And we have developed something in Root, which is called as a Dragon Scan, and it is giving us really cool results. And we also have Shining 3D photogrammetry with us, and we are already, like, with each passing day we are developing and improving the system, especially from this perspective. So I hope and it will be an amazing course. I'm sure, like, I really want to attend and see Dr. Adam performing surgeries. I would really love to assist him, and we will be enjoying, and we will also have some good arrangements done. We can visit the mountain which is there in Mexico, in Colombia, sorry, and there will be good dance. So it's like a fun trip included with learning and with Adam. So I hope you guys
Mhm.
will enjoy this overall experience. Also, it is also great for the Latin region and Spanish-speaking population, because we will also have Spanish translator, and it will be quite good. For the second one will be happening in some other country. So we have three
Mhm.
master classes scheduled with Dr. Adam this year, and we will release it like on a timely manner. But the one which you can confirm right now will be for me,
Mhm.
and I'm telling you, it will be
Hopefully,
really
yeah,
interesting and
sorry to
interesting.
interrupt you. Hopefully we will do something also as an old school. Not all the speakers want to do this, but I would like to do this, to do not only live surgery but also surgery with participants of the course. They're
Of course, of course.
operating on the live patients. Yes,
So
so
we have planned something like
Mhm.
this, Dr. Adam. We have also planned something like this in which the participants can place
Mhm.
implants inside the patients, and they understand the full workflow that you narrated,
Mhm.
from planning,
Mhm.
segmentation, and also your scanning and the prosthesis. So I think
Mhm.
this is something which requires a lot of logistical efforts and the
Yeah,
right
yeah,
country and the right location to do it. So it will be there, it will be happening.
yeah.
We just need to keep it a little bit surprised. So we will launch this soon as we finalize with the patients, because also it's also a good, like, huge responsibility to complete the
Yeah,
patients
yeah, yeah, yeah,
immediately.
yeah, yeah. We have to treat everybody with due respect. This is a huge possibility to learn for you guys, and to do really things that you are a little bit scared, maybe in your office, in your practice, to train. But this is also a huge responsibility. So for me, I'm really happy that I have this possibility to conduct this type of trainings, which I did, and which we will do together with Salman. So
So thanks so much, Adam. I
yeah.
think we already are right on time, and if anyone
Mhm.
is having questions, I quickly see it. Okay, so we have few interesting questions, by the way. Uh, so, Adam, you're already a master in terms of material selection. So, I
Mhm.
have a question about material. Like, how do you select the materials according to the case? Like, if it's an FP1, you directly go with all zirconia. If it's FP2, what is the choice? Or FP3, what do you recommend?
Mhm. To be honest, the most common material that is made, the most common situation. It doesn't matter if it's FP1, FP2, or FP3. Is that we do this titanium bars right from the multi-unit, and with zirconia taco. Uh, let's. I will put it like this. Not all the techniques, not all
Yeah,
the
yeah.
techniques work in my hands. So I cannot, ask my technician to do something that it doesn't work in his hands. I work with really, really top tier guys, which for me are people that I learn from. It's like you learn every day something new. But these guys are really, really wise, and we are like a team. So if they say, man, for us, this is better, easier, this is bulletproof, idiot proof, I follow, because for me it's like I had issues. I had some situations that in the past we did FP1s, and it was full contour zirconia with the T-bases that were glued in, and it worked. Still, something snapped. So the patient had like I don't know, some trauma, or maybe she or he had some bitten something hot, bitten on something hot, and there was a crack, and we had to replace it. So it didn't happen with FP3s. I didn't have these issues, but with the FP3s, with the full contour zirconia, I had the cementation of the T bases. So because they told me that uh, it will be easier for us to do some cases like this as a full contour zirconia, but we have weak cement. So this was the narration of the
Uh-huh.
technicians. I cannot tell. Then I have shown you also the FP3 with the titanium bar and T bases that were cemented in. So this is a little bit more expensive with the pots, and it's a little bit more expensive with the laboratory time. So for the technicians nowadays, when they have these milling strategies that they can, have this 5-axis milling machine, so they are milling,
They
in
can mill
every angle almost.
everything.
Yeah.
Yeah.
So for them, it's like easy, and they know the shrinkage, everything. So it really fits like a hand in a glove. So for me, like a final restoration is simple, and I follow these guys because I know what they are speaking about. I cannot say that porcelain fused metal is bad, because I did this and it worked till some point. And also, I cannot say that full zirconia is bad. No, but it's heavy also. It's
Yeah,
like a
but
300 grams.
that's something which, especially when you're dealing full arches,
Yeah,
weight is a concern. Like if you have FP3, then if you do even metal ceramic, it becomes too heavy
yeah.
for the patient.
Yeah,
So they start complaining.
this comes elderly granny, and she has 300 grams in her mouth, and she's always open
Okay.
because it's heavy. Yeah, so the muscles are in the atrophy, are weak because of the age. So it's like it's a stupid joke, but still it's really heavy when you compare it in your hands. Even it's not 6-7, it's really heavy.
It's really
So yeah, so let's say that this is the first thing, but the temporaries, this is I think this is more hot topic, because we were struggling with one workflow that will work for all.
yeah,
It's
absolutely.
almost every part of this workflow is more or less really really advanced, and it's easy, and it's easy to be easy to be taught, or easy to learn, and it's really well developed. But with the temporaries, oh man, this is something else. This is also the situation with the jigs, and also the situation with the materials and the scanning, because not everybody can have this possibility to have this scanner, and that scanner, and
Yeah.
everything in one office. I understand this. I have this privilege to have them, but still, it's not. We cannot say that this is like a common thing. We're doing research, and this
And
is
and
something.
and
Yeah.
realizing this, like the technology is shifting too fast. So I
Hmm.
think there is nothing as a bad scanner. Like everyone eventually will be good scanners in the
Yeah.
coming time.
Yeah.
Uh, there is one more good question. This is about the choice of guide.
Hmm.
So, which guides do you prefer and when?
Which guides and when? Oh man, I have shown you many designs of the guides. It's not. I have to be really in this situation. I have to be very honest. I'm trying to do as low as least as I can, without going fully navigated. So for me, the guide, the you know. The easy it's like the easier the guide, like a simple guide, for the pilot drill, not very bulky. It's the easiest way, because I'm really I operate better, with my hands than with the surgical guide. In my as I mentioned, and I was really honest at the very beginning. I was really really in love with the fully navigation. You have seen the design of these
Mhm.
guides. They were crazy, but this is more like designer stuff than doing real operations. Real operations require, if something is more simple, it's a bulletproof, it's idiot proof. So sometimes you're in stress doing something, you're in stress. So if it's something is simple, it will work better than it's complicated. Complicated drill patterns, complicated drill trajectory, complicated bone density, everything. You can give A4 sheet with the information how to do something. the I think the operator will forget about it. Yeah,
Yeah,
so
yeah.
for me
It,
it's
it,
easy
it
to
it's,
use.
it's the skills will be forgotten
Yeah.
if
So
it's too
so so
easy.
so even for me, it's easier to use unified implants. So the same platform, the same length. I don't have problems during the surgery where I have and I don't have to look aside to the screen which implant should be there, or ask or shout to the assistant, the dirty assistant, the clean assistant is here. Show me this implant in this 1/6 region because I cannot remember. Yeah, yeah. And the patient on the unit is shaking because he knows that something is going bad. Yeah, so we are trying to simplify everything that is more simple. It gives you less complications. So for me, really easy, simple guide. It's easy to learn also. and it gives you less complications, by the way. So
And most importantly, you should design your own cases. You should never
yeah,
depend on someone to design your own
yeah,
cases.
yeah,
Like, I
yeah.
think we both learned it the hard way.
Hmm.
And I think the pilot one is something that everyone should go initially, because
Hmm.
fully guided sometimes will blind you. In
Hmm.
my opinion, you should always go with the pilot drill guides, and it's much more easier. You have better vision, and you still develop the surgical skills for the fully
Yeah,
guided to come.
yeah.
One more question. I think probably this is the last one we can take. Uh, this is about bone reduction.
Hmm.
Oh, and it's also about the reverse planning. So,
Hmm.
how much the bone should be reduced in situations? It's very subjective, I understand. And what is the importance of designing the occlusion before you go ahead for the final?
Yeah, so basically everything what we do should be prosthetically driven. So when we have a full arch, or let's say semi-full arch, we know where the teeth should be. And when we know where the teeth should be, we have this reverse engineering that we know where the implant should be placed. Because when we eyeball it just, and we have a patient and we try to place the implants just eyeballing on it, it works. I know many guys that they are very skilled operated, but still they try to, they open the flap, they cut the flap, and they search for the landmarks. I know, I have seen this, and I do the same because they don't have, the measurement tools in their hand. So they measure, they search for the landmarks, and the simple surgical guides give you information where to start drilling and which angulation, and this is it, and this is enough. Yeah, and so basically, when we know where the tip should be, we know where the implant should be to achieve, let's say, certain pattern. And this pattern it gives you this nice mucosal shape of our structure. This the hygiene is the key factor for this big
Hold on.
cases. Yeah, when the patient remains with a good hygiene, everything will work, even if it's not aesthetical, because we aim at the aesthetics, but the function comes first, and the hygiene is the very ground base of everything. When the hygiene fails, everything will fail. So the hygiene, the patient has to have this possibility to clean everything underneath our structure. So let's sum up this all together. When we know this, where to place the implants, we know also how much tissues we want in between the apex of the pontics of our teeth and the implants, and we know still which accessories we need, which multi-units we want, if we want angulated, if we want
Mhm.
straight, what height of this multi-units. Still, I order more and in different shapes and heights, because I know that something can happen during the surgery. I will have the spinner. I don't have this primary stability, so I will put the wider implant, or maybe the longer one. So still, I just want to have something, in my backpack, or in my because I don't wanna risk that operation will be a fail due to my incompetence, because I didn't order everything. And then we know how much bone we want to reduce. Basically, I try to not to over reduce. I try to reduce to the every aspect that is above, because we every aspect that is above, let's say, outline of maxilla or mandible, because then if we place the implants without bone reduction in the mandible, in
It's
example, the existing teeth, they are mainly in the anterior region.
yeah.
So when we have like a
So
everything, let's say
it's like a
everything
bow.
feels is slope. It's like a Hulk Hogan's mustache, the
Yeah.
final restoration looks like this. Yeah, and it's like it's uncleanable. We are not able to clean underneath it. So if we will have unified height of everything, it's easy for the patient. And this reduction, we shouldn't be scared. I know that some guys like perio guides say, oh no, don't reduce, design the bone, grow the bone. I know everything, but still, when you have a full arch, it's, you cannot extract you and try to, to do bone, to build the bone, even if you are highly
And
skilled, because the patient has
it's
to
also
be.
quite, I think it's also quite difficult to do grafting in full arches because you
Mm-hmm,
will never have the quality of bone that you're looking for stable
mm-hmm,
implants.
mm-hmm.
And like I love the way you design the cases because you have an assessment of the load bearing, because implants are great for taking the loads in the long
Yeah,
axis, and your implants are obviously, like, all of them are along the long axis. Even when you try to tilt them, the multi-unit head
mhm,
is in such a way that it's aligned, so the
yeah.
arch, the whole displacement and the AP spreads it
Mhm,
accordingly. And I think that's the reason for the success, because
mhm,
placing implants and doing prosthesis is not enough. It's also about
mhm.
assessment of the future load and the long-term success, that how the bone will react to the upcoming load to avoid failures. So I think, thank you so much, Adam. It was a lovely session, and I'm really grateful for you doing this immediately after your vacation. I know you had a tough day today at the clinic and you just came back, and it was really informative, and we are looking forward for great attendance on for this masterclass. And we will have Spanish translators because it's in the Latam region, and people will come and enjoy. We will try to cover as much things as possible. Thank you
Yeah,
so much.
I'm
Have a
really,
good
I'm
night.
really grateful that I could do this speech. Thank you, guys. Have a nice evening. Bye.
You too. Bye bye. Take care.